So our session today, our TA session today, is on optimizing telehealth technology for HIV care. And just a reminder that this is a TA session in Health HIV's telehealth learning cohort, where we will have 3 technical assistance sessions, a larger webinar in December, and a number of resources that you can access in our Google group. And we'll just note a reminder to share anything you want in the Google group, pose questions, and we'll continue to engage with you via the Google group in between our TA sessions.
I'm going to now turn it over to our first presenter, Dr. Jeremy Young.
All right, thank you. So to introduce myself, I'm Jeremy Young. I'm an ID physician at The Ohio State University Wexner Medical Center. And starting my telehealth career started about 12 years ago when Melissa Badowski, the other presenter, and I 12 years ago started a prison telemedicine program at UIC, which she'll probably talk about a little bit. And that's a synchronous video kind of telehealth program. And then since coming back to Ohio State a couple of years ago, I do lots of modes of telehealth. Of course, during the pandemic, everybody started to use it. I still see about 25% of patients overall in our clinic are HIV patients using synchronous video visits. And then do outpatient EConsults, which I'll talk about as far as like rapid start and prep and things like that, and inpatient EConsults as well. So these are just the learning objectives, and I don't know that we need to necessarily go through those since we are short on time, but I'll talk a bit about the public health emergency on this first slide here. So obviously COVID, the pandemic changed things. It changed the necessity to use telehealth, but it also changed some of the rules and regulations around it. And I think that's important to understand, which is why I wanted to start with that. So the federal public health emergency was declared in January of 2020. And there were other bills as well, the Emergency Appropriations Bill, the CARES Act that was passed in March, the HEROES Act that was passed in May. And all of these sort of combined provided telehealth waivers to remove barriers to care because we knew we didn't want people coming into our clinics, people were on lockdown. So it expanded reimbursement. This was huge, again, why we continue to see 25% of our patients with telemedicine. That's how we can manage to do that. Easing of professional licensing requirements, waivers for certain technical requirements. There used to be requirements for the originating site, which is where the patient is. Some, depending on the services, some had to have what's called a telepresenter, so some healthcare professional there to take vitals and work the equipment. People had to be in a rural area. That's no longer the case. The types of professionals who can use telemedicine. With the history of telemedicine, it sort of all started with telepsychiatry, so there's a grand history there, but there are some other subspecialties that have been more recent. Reimbursement for audio-only visits, that's also been huge. Lawyers can bill for telephone calls, but we never could, and now we can. And then this is key too. I'm going to go through some of the platforms, but it allows for the use of non-HIPAA compliant technologies. And this is for the duration of the public health emergency. So the public health emergency has now been extended at least through the end of December of 2022. And I think a couple of weeks after that too, just because of some congressional calendar stuff. But so we've got more than another year of this, and individual states along the way have passed their own regulations. So for example, in New York, we have a bill going through the state legislature here in Ohio that will hopefully make some of these changes more permanent. Go ahead and advance to the next slide. So this is just an example of how at Ohio State, how our use changed during the pandemic. So in fiscal year 2020, we grew from 800 encounters in the first quarter to almost 200,000 encounters in the last quarter alone. These are video visits. This saved our patients nearly 8.5 million miles driven. We have a pretty large catchment area, about 400,000 gallons of gasoline, and about 3,000 metric tons of carbon dioxide, which is the equivalent of powering about 683 homes for 1 year. So there's an impact. Next slide. So the platforms, I really want to drill down on this. So there are EHR-based platforms. We use an EMR here called Epic, and that has a video visit component to it. That is obviously HIPAA compliant. It just goes directly through their electronic medical record. Some of the problems, not all EMRs have this ability, so that's important. But I've found a lot of patients have difficulty with it. They have to register for something called MyChart. They have to have an up-to-date account. They have to access it. And then once they access it, they have to access the video visit function. And there can be some issues. There's third-party HIPAA compliant. So I have no conflicts of interest. I'm not getting paid by anybody. I use UpDocs. We have an institutional subscription to that, which is why I use it, but there are a bunch of other ones. Some are free, some are not. And I have some of them listed there that are HIPAA compliant. And then there are third-party HIPAA non-compliant. And this is important because you're allowed to use these for the duration of the public health emergency. This is something that, while in my opinion, it's probably no longer necessary, and I would highly encourage you to use HIPAA compliant technology that's fully encrypted. You can use things like FaceTime and Zoom for the public health emergency. Go ahead, next slide. Different types of telemedicine. I think you probably know this, but there's synchronous, which is just a real-time visit kind of over video or over the telephone. Asynchronous, which is something like EConsults, where instead of provider to patient, it's provider to provider, and I review history and images and labs and microbiology if I need to, and then give recommendations. Our EConsult program, so I heard someone mention Rapid Start and HIV prevention with PrEP. Most of our Rapid Starts and most of our PrEP is done with EConsults. And then MHealth. I'm not a big MHealth proponent or user. I'm going to mention a couple of the platforms a little bit later on with MHealth. These are very inexpensive. So these are things like text reminders, anything you do through a smartphone that's generally asynchronous, remote monitoring, things like that. And I'll show you a couple examples later. Next slide. So as far as the efficacy of HIV care, longitudinal HIV care with telehealth, we know that it works. The whole idea of synchronous telemedicine with a video visit is to replace the in-person visit, to make it essentially the same. And obviously there are some times where you wouldn't want to use it. You're having serious, end-of-life discussions. Maybe somebody has, a fever and a rash, and you really need to bring them into clinic. But otherwise, in general, for the longitudinal management of HIV, it works very well. And this is a study we published back in 2014 with our prison telemedicine program. So pre-telemedicine, they had on-site generalists managing the prisoners with HIV. And then, so we looked at a couple years of that, and then a couple years post when we took over as subspecialists managing HIV in the prison population. And then go ahead to the next slide. And what we found is, regardless of CD4 count, and we stratified it here because back then there were still changing guidelines as far as when to start, unlike now where you start everybody, hopefully rapidly. But regardless of what their CD4 count was, the telemedicine virologic suppression was significantly greater than the pre-telemedicine virologic suppression. And I think this tells us two things. Number one, it is important to have expertise and have expert consultation, another thing that somebody mentioned when managing HIV, but also that telemedicine works. And we didn't look after the national recommendations were changed just purely at that period. And anecdotally, I would tell you probably in that program when I left, close to 100% virologic suppression. There were a handful of patients who were not suppressed. Go ahead to the next slide. So EConsults, again, I do outpatient and inpatient, and this is for Ohio State patients. I do it across the spectrum of infectious diseases. So there are a lot of different questions that people can answer. Obviously, we get a lot of SARS-CoV-2 questions, but this, I just wanted to mention, as far as HIV goes, we answer questions regarding testing, regarding abnormal testing, false positives, testing in special populations, and then of course doing rapid starts and doing PrEP. Most of our PrEP patients at Ohio State just follow with their primary care physicians, and we generally just do EConsult PrEP. Go ahead and do the next slide. This is the concept of EConsults, and this is just from the AAMC. They're very big proponents of this. Typically, particularly kind of in an academic medical center, you have a primary care physician, they have a question, which is often very straightforward, and they put in the referral and call scheduling, and you maybe wait for months to kind of process the paperwork and call the patient and set up a time. And then the patient comes in, and then the specialist says the next best step is, whereas an e-consult, it's much more direct provider to provider. And go ahead, next slide. So this is just an example of sort of an e-consult. Somebody can put in photos and put in basic information, and you can look over their labs, and you enter it in an asynchronous fashion, so you're not seeing the patient. Go ahead to the next slide. So as I mentioned, we have e-consults for almost anything you can think of with infectious diseases, but this is just our order. This is a screenshot of our order for abnormal HIV testing. And people put down whether there's acute retroviral syndrome, signs or symptoms, their risk factors, significant exposure, whether it's injection drug use or sexual or something else, specific clinical question, and then they have to consent to it. Next slide. So this is what it's done to our clinic lag times. This is just kind of a side benefit before e-consults. And again, we do them for not just HIV, but everything. Our time to first visit live in person in our clinic was 84 days. The mean time for me to complete an e-consult has been 21.7 hours. And the time to first visit after we implemented the e-consult program is now down to 14 days. We hired a couple new faculty, and there are other factors too, but just wanted to throw that out there. Next slide. Okay, MHealth. I wanted to bring this up because this is very common in HIV. Again, I'm not an MHealth user. And also, we don't have a lot of very longitudinal studies. Most go sort of 6 months or a year. But when you look at more longitudinal data, a lot of these MHealth interventions don't necessarily have long-term effects in HIV as far as really affecting those aspects of the care continuum that we really think about, like adherence and virologic suppression and retention and care and things like that. So this involves a lot of things. We generally don't do wearables, but you can. This is mostly things like texting, social media. So you might text people with medication reminders, using private Facebook groups to have group discussions, to talk about risk factors, talk about concerns or questions, which I'm also not a big fan of. There are some FDA-approved devices and apps, but many haven't gone through the process, so you always have to be careful. There are 1,000 different apps out there that you can use for MHealth as far as texting with patients and things like that. But again, I'm not a huge user. I'll show you a couple of examples if you go to the next slide. So here's just one example. This program used a digital HIV care navigation app in young people living with HIV in San Francisco, and they looked at 6 months. Participants in the program who downloaded the app had increased odds of viral suppression at 6 months. Again, with a lot of it's a small study, a small sample size, and when you look at the more long-term effects, a lot of this doesn't necessarily stick. But some of these interventions, again, they're very inexpensive, they're very easy to use, very user-friendly. Go ahead to the next slide. This is another one. This is called Positive Links. It's a mobile technology to improve engagement. Again, they looked at 6 months, very small number of patients, only 127. This was using things like text reminders to take antiretrovirals and engagement in care. So basically showing up to their visits, and viral suppression improved significantly at 6 months. We can go into the next slide. And this is sort of my last example here, but again, another fairly small study. This is something called WeCare. Again, these are all just different apps. And this also involves social media. My concerns about that are privacy and not just privacy in general and protecting protected health information, but a patient's perception of privacy. I could see a patient saying, I don't want Mark Zuckerberg to know I have HIV. So I don't know why they would post protected health information in a private Facebook group, but that's this intervention involved private Facebook groups. And there were significant reductions in missed HIV care appointments, increases in viral load suppression up to 12 months post-implementation. So I wanted to give you some examples and throw out there that there are some platforms that, again, are very inexpensive, very user-friendly, involving things like texting. Some things are a little bit more time-consuming, like having a moderator in a private Facebook group who's answering questions and things like that. But anyway, go to the next slide, please. I want to talk about some barriers to implementation. I know I don't have a lot of time left, but I'll kind of quickly go through these. Depersonalization, privacy, confidentiality, the digital divide, and then reimbursement, which unfortunately is a reality that we have to deal with. So go ahead to the next slide. So depersonalization, it's important to establish trusting provider and patient relationships. And it's particularly, I think, important in HIV care because we talk about things like sexual history and drug use. We know it's efficacious. So particularly, I think synchronous telemedicine, things like video visits, but know when not to use it. Things like serious diagnoses, end of life issues. As I mentioned, the patient has a fever and a rash, they probably should come into the clinic. Patients' perception of technology and trust of Western medicine is influenced by things like socioeconomic status, beliefs, and culture. So keep that in mind. There are some people who have a great distrust of not only the medical establishment, but of technology. And then some people, what I typically do in the clinic is a first visit in person with an opt-in approach to telemedicine. As I mentioned before, about 25% of our HIV patients in our clinic have regular telemedicine visits, maybe skewed with in-person visits so they can get labs. Go ahead to the next slide. Privacy and confidentiality. This, again, even though we have the public health emergency and you can use something like FaceTime or Zoom to connect with a patient, I would highly encourage you to observe the HIPAA privacy rule. Do no harm, practice non-maleficence. Make sure that you have encrypted visits. So try to use something that's HIPAA compliant, update and maintain firewalls, store any protected health information in the electronic health record. Any video, again, I would discourage you from recording video and audio of patient visits, but make sure if you do that it's behind a firewall. And if you do research, there are resources out there. My favorite is this core initiative that's at UC San Diego, and it's a free resource, and they have experts in telehealth and MHealth to answer sort of ethical research questions. And then go ahead to the next slide. The digital divide is real. Socioeconomic issues and social determinants of health affect telemedicine readiness. When you look at things like income and housing instability, mental health, substance use, education, digital literacy, geography. So my father retired to a very rural area and he didn't have access to broadband until like a year and a half ago. So the geography matters, broadband connectivity, the language spoken. So access remains an issue for some people. This is common not only among our general ID patients, but our HIV patients. We have a big, so we have an urban population, but we have a huge catchment area, as I mentioned before, and we have a very big rural HIV and hepatitis C population, and some people don't have broadband connectivity. Go ahead to the next slide. And this project's kind of small, I suppose, but this is just a Pew Research Poll looking in 2019. Who's not on the internet. So 10% of US adults in 2019 were not even on the internet at all. Didn't seem to be much of a difference between men and women, but as you can see here, who's not online, it's less in white than non-white folks. And then when you look at age, there's a huge disparity between people 18 to 29, everyone's online. But when you look at 65 plus, and a lot of our HIV patients are 65 plus nowadays, at least a quarter of them are not even on the internet. People who make less money, so less than $30,000 a year, about a fifth of them are not on the internet, at least weren't in 2019. Less than high school education, almost a third not on the internet versus high school or college plus. And then urban versus suburban versus rural. Again, a lot of rural folks and even some urban folks just don't have good access, online access. Okay, next slide. So we actually have a policy paper about this through IDSA. I'm very involved in the IDSA Telehealth and Emerging Technologies Work Group. And this is just a paper that we wrote about the digital divide and can give you more information in there. Go ahead, next slide, please. Reimbursement. This unfortunately is important in medicine. You can bill private insurance, Medicare and Medicaid. Reimbursement rates vary by payer. I'll show you a slide, I think it's the next slide, a little bit about payment. Specifically, you may need to meet specific platform use and documentation requirements. The big thing I always say is if you do a video visit and you're going to bill for it, the most critical part is that you document time spent, and that includes chart review, time spent with the patient, and then medical decision making, and then documenting that in the note. Some do an out-of-pocket model. This was big a few years ago. A lot of drugstores, CVS and Walgreens, were trying to do sort of out-of-pocket per-click models of synchronous telemedicine visits for things like sore throats and everything. Next slide, please. And this is just, these are the codes here, and time spent, and clinicians or non-clinicians probably don't know much about RVUs or care much about RVUs, but this just has to do with reimbursement and compensation as far as on the right there, the 2020 RVUs. So again, I always make sure that you do the right CPT code, that you document exactly what you did. Was it a telephone visit, a synchronous video visit, an EConsult, what have you, document time spent, and then those are just the sort of RVUs. Next slide. And I'm wrapping up here in just a second. So broad advice, standardize your approach as a medical center, practice, or clinician. Provide scripted education for patients in their language and be able to answer questions. So I consider myself IT support. I'm tech support for my patients. You don't just have to use your smartphone, so you can use things like a laptop or what have you. Keep confidentiality in mind. So when I'm doing a video visit, I'll often do it from my office where I am now, make sure the door is closed. I always use a headset to make sure that people walking by can't hear protected health information. Consider what is not appropriate for telemedicine. I've mentioned that a few times. And then I would highly recommend you develop comfort using only one HIPAA compliant encrypted platform. Again, I use UpDocs, but that's just because we have an institutional subscription to that. It works really well. It's super easy for the patients. You literally just put in their phone number, it texts them a link, they hit the link, and they start the video visit. It's very easy. Much easier than doing it through the EHR. And then next slide. And we also have a checklist. I also recommend this if you're going to do synchronous telehealth. When people register for the visit, this is kind of an example checklist that we go through for patient details, language needs, identifying hardware and software needs, what platform are they going to use? Do they want to go through their Epic MyChart? Do they want to use a third-party provider? And then any other assistance needs. Go ahead to the next slide. And then we actually, in IDSA, we have two position statements actually now about the use of telehealth and telemedicine and infectious diseases in general. And we have a lot of HIV talk in this paper as well. You can always reach out to any of us, but I think the paper provides a lot of good basics for the use of telehealth with HIV and with ID in general. And then go ahead to the next slide. And thank you. That's my email address. Feel free to reach out. That's my professional Twitter. And just in being cognizant of time, I will send it over to my former colleague, Melissa Badowski.
Thank you very much. And so I am still at UIC, but I had the fortune of starting the program as well, which is an interdisciplinary program. So I'll talk a little bit more about that. Next slide, please. And there's some objectives. We'll skip this. It's in the slide deck, but we'll go into the next slide. So we know that with HIV that we can use telehealth for just about anything now. So we can use it for diagnosis, for treatment, for prevention, but also for the public health response so that we can use more scale-up approaches to provide more care for everyone. So it's not just limited to a certain disease state, limited to a certain patient population. Next slide, please. And so now we're left with this pivot of going back to the real world, going back to regular care, being face-to-face, and doing telehealth care because people still are wanting to do telehealth. People, our patients, us as practitioners are looking to do it. So now we're pivoting back to do we do telehealth? Do we make people come in face-to-face? So we can actually provide and offer the best of both worlds for our patients. Next slide, please. So when we're navigating this hybrid approach for our patients, first and foremost, we need to make sure that we're trained on how to use this technology. So as Jeremy said, we are the troubleshooters for technology. And so you have to be comfortable with using the technology. So not only if your providers are using it, but also other staff members who are checking in our patients, But then also the patient and caregiver need to be able to have a level of comfort, or people are going to just be turned off to using the telehealth modality as a whole. Now, when you're starting a program, some of you have already started a program, and so you know what's working and maybe what's not. But if you're going to expand services, if you're looking to branch out, this is something that needs to be continuous. It can't just be at the start and you never look at it again. So that's just something to consider as you're navigating this new hybrid model. The other thing needs to be, what does the patient want to do? Do they feel comfortable using telehealth? I know the other Melissa had said that a lot of moms are looking at this because they need childcare and maybe for getting from point A to point B. So this has become a huge way to alleviate stress for a lot of people. They can maybe do it on their lunch hour. So that's something also that needs to be considered. What does the patient ultimately want? Next slide. And so from our medical perspective, I like to think of it from us, from the patient, from a little bit of a different thing. How can we best fit this into our flow? So we could stagger our virtual and on-site visits. So we have some providers who will do a whole on-site day. We will have some that will do all virtual. Even within my clinic that I have, we have a mix of on-site and virtual. So we kind of intersperse those throughout, because if a patient's maybe running late for the on-site clinic, we can go and see somebody virtually. So, looking at just different schedules and the flow for clinic. In terms of interdisciplinary integration, that's something that our model has always used. And I can tell you, it is an amazing thing to be able to integrate everybody into one clinic visit. We have the physician, myself being the clinical pharmacist, a case manager, as well as a nurse who is involved in this visit. So from our perspective, if we're doing it for a prison visit, the nurse is on site and helping to facilitate the exam for the patient. But what it comes down to is we are seeing people in 15 to 30 minutes. I like to call this like drive-through medicine, because you're getting access to all of these specialists in their areas. And so if you wanted to do, maybe dietary, if, a dietitian, anything you can potentially think about adding into that. Each of us have our own expertise in that area. So I would strongly, strongly suggest trying to integrate an interdisciplinary team. Now, the other part is being able to minimize these virtual wait times. And I can tell you, when we're seeing patients, our clinic flow is really quick. So we sometimes get to go on to the next patient a little bit more quickly. And this has significantly reduced our wait times. Next slide, please. So the biggest challenge, I think, throughout the pandemic was how do we get labs for our patients and incorporate that into our telehealth visit? So, our model, where we have been doing this for a very long time, is that we've been able to obtain labs that were on site at each correctional facility. We also branched out to drug treatment facilities. And so when these labs were reported, even though that they were processed on site at the University of Illinois, we still were able to upload this to a cloud-based platform, which it is called Formedica. And so you could access it through a secure login, and you're able to access the patient's labs anywhere that you go. So it didn't rely on the electronic health record. So then we actually switched platforms from Cerner to Epic a few years ago. And now our labs are all able to interface with the electronic health record. So we're able to see it there, but there's still this cloud-based service for the correctional facilities, because they do not have the same electronic health record capacity as we do. When we look at our outpatient and ambulatory care clinics, we've been a little bit, definitely during the pandemic, a little bit more lenient about getting labs. But again, we're able to obtain labs that are at a convenient time for the patient. Is it before their visit? Is it right after their telehealth visit? But the other thing is, maybe if we're just reviewing labs, this is a perfect place to have the patient use as a telehealth visit, whether it's on the phone, whether it's through a video, just like we're doing now. It makes it a lot more flexible. The other thing is, we can schedule it within our hospital system, and a patient can schedule the lab appointment, but they still have to come on site to get them drawn, especially with our chronic disease states for HIV, at least for a viral load or a CD4 count. But we can also consider using clinical laboratory networks. And so the one thing that I would caution is to make sure that a patient's insurance is able to provide coverage for that, because your patients will be pretty upset if they incur a bill that is not something that's covered by their insurance. Next slide, please. And so the other part of it, if anyone participates in the VA, there's been a huge expansion for that. And it's from their main facility. They have a bunch of these community-based outpatient clinics where a patient will usually be assigned to care. And so that's also means for their lab draws as well. So, if these patients are in a rural area, they still will have to go to get these lab draws done. But the other thing is they can do it at a time that's more convenient for them. The other thing with some of these peripherals that we're using, and I'll talk about that very shortly, we're able to get a lot of our data from that. So that makes it a lot easier. And we don't have to bring the patient who may be in a rural setting or many, many miles from their community-based clinic to the site to have their blood pressure monitored, or to have vitals collected. Next slide, please. And so just a little bit on the interoperability of an electronic health record. So we are able to obtain informed consent this way, through the health record. Even with Epic and MyChart, yes, there is the onus of setting it up through MyChart, but in the middle of a telehealth visit, and I can say even with our prison population, their information is in Epic. We can, if we need to fax them a form securely, they sign that they are able to engage in their care everywhere. And so if they were hospitalized, or we had further questions about additional follow-up that they've had, this will all go into that EHR so that we're able to see that. So that's still something that we're able to navigate. With our system though, this is now for the prison system, this isn't for everywhere. What we do still have different record keeping systems. So our electronic health record will house our medical notes and our records, but we can still securely fax it over so that the prison will be able to keep track of their records for the patient. So when the patient is requesting their files once they leave, they're able to have that provided to them. Next slide. And so some of the troubleshooting aspects of technology, they seem kind of like dumb moments where, we know we all need to restart our computer or device. And my husband tells me that when I'm having issues, but that's something that can definitely be done. But with all of this, we're able to navigate, and it's just some quick fixes. And I'll leave this for you because I know we're running a little bit short on time. So next slide, please. In terms of the identification and procurement of telehealth peripherals, there are a ton of them, and it's basically about what are your needs. Next slide. And so what is going to be the most important for your clinic site? What are you hoping to accomplish? Do you need to diagnose? Do you need to just purely use it for patient monitoring? So really honing in on what's you absolutely need. That's what will navigate your choices in these telehealth peripherals. Next slide. And so it is going to be able to transmit information between sites. So we have an electronic stethoscope, we have an electronic exam camera, and they can send images in real time if a patient has a rash. We can hear heart and lung sounds in real time. So if for this, it did require a telepresenter or our nurse being on site to be able to do this. Now, there's other considerations that you need to think about. Is it going to be something that's wired? Will it need a specific cable? What if that cable is missing or somebody else uses it, which happens quite frequently? do you have backups for this? This is something that you need to consider. For some of the wireless peripherals, it makes it, Wi-Fi or Bluetooth. So you have to really decide what it is that you're asking your patient to get. Is it going to be covered, or is it going to be an out-of-pocket cost? With going back to some of these wired peripherals, some of them use a little bit older technology, and it's an analog technology that they're using and an analog signal. But this makes it harder for hackers to tap into. So, when we're thinking about HIPAA compliance, these may be some of our things that we want to use for being those wired peripherals. Next slide, please. So there are a few things that you want to make sure that you're going to consider. What do you want it to do? Is it user-friendly? Because if there are a bunch of barriers, especially for your staff, for your providers, people aren't going to necessarily want to use it. I know, with our stethoscope, if people were unable to find the extension for it, that was something that was going to be an issue for, making sure that we had heart and lung sounds. For the patients, if there is more hassle than it's worth, they're going to want to revert back to those in-person visits. So that's another thing to consider. Also, portability. Is it something that's really heavy? It's not going to be able to be moved if it's a hardwired thing. So obviously you want something that's going to be easily moved. Next slide, please. So additional things, setup. Is it going to be easy? Is it just going to be out of the box, you plug it in and you're ready to go? Or is it going to have to have any programming? The other thing is with training and support, what's required for the equipment? Is there going to be maintenance? Are there going to be updates to it? What happens if the equipment breaks? And so our hard drive crashed a couple of years ago, and thankfully we had a warranty and it was fully replaced. So these are all considerations that you want to make sure that you have. Software, is it coming with its own software, or do you have to have specialized software? So that's another cost that you would think about. And so obviously cost is going to be something that you need to think of upfront when you're putting in your budget constraints. But then also you need to think, yes, it might be cheaper, but is it going to accommodate what you're looking for? So kind of take home, maybe go for the middle of the road. Don't go for the most expensive or, not as expensive. But, with some of our cameras that we have, maybe a $25 computer camera that you stick onto your device is going to be all that you need so that you can see a patient. So really doing your homework with that is going to be very important. Next slide, please. So I provided you with some of the top 5 areas or companies that provide telehealth equipment, peripherals, carts. Sometimes the carts that you make yourselves are going to be cheaper than what's sold in a package. But also then if you are going to have carts that you're buying 1 versus 20 of them, you'll likely get a discount on that. So that's also something to keep in mind when you're purchasing. Next slide, please. And so I want to finish with the training aspect of it. So how are you going to get your patients, and what do you need to make sure that they're going to have a good experience with all of that? So within the medical team, it's going to be interdisciplinary. Every single person needs to learn how to use the equipment because everybody may get a different aspect of it, but they still need to know how to troubleshoot and navigate it. So obviously with the program implementation, everybody needs to be onboarded, but the problem is that some people will end up leaving. And so you constantly need to make sure that you're assessing on a continuous basis if a patient is, or not a patient, your staff is able to continue using this and using it correctly. Making sure that people are trained appropriately with cultural humility. And so we want to make sure that we're combating stigma as well as misinformation for our patients. Now, I will say when we first started our program, I will never forget we had somebody who was helping to facilitate at the Department of Corrections, and a patient wasn't comfortable coming into it because it was new to them. They hadn't heard about it. And the person who was helping us facilitate the visit goes outside in front of everyone and says, if you don't come and see the UIC medical team, you're not going to have your HIV medications refilled. And so I remember this very early on, and we couldn't actually have that person help with the telehealth program anymore. So that was a big issue for patient confidentiality. Of course, this was new to them, but I don't think that person on site had a lot of training on how to use telehealth since it was so new. So, making sure that we are looking at all of those issues and making sure that everybody's comfortable with it is definitely very important. I'll skip to the next slide, please. The other plug is not just always looking at the those who are in the medical field, but those who are going to be entering the medical field. We need to be training our students, our residents, our fellows, because if they're not comfortable with it coming out of a training program, how are they going to be comfortable with adapting and adopting it when they are on their own in practice? So making sure that there's shadowing opportunities or there's simulated experiences so that a trainee can learn how to do it in that safe environment and learn some of the do's and don'ts about telehealth is extremely, extremely important. Next slide, please. Patient recruitment. How you get your patients, there's going to be a lot of different ways. And these are just some of the ways that you can consider through a website, through being in the office, through social media, or being local newspaper or radio. So these are just definitely ways to help to get the word out. Next slide, please. And then this is kind of who is the ideal candidate. So basically anyone who, voices interest, any way we can reduce barriers to getting patients into a telehealth visit. These are just kind of some of the things to consider. If they need a physical exam, that's going to not necessarily be conducive, but that's something to consider maybe for a next visit when it's a follow-up for lab. Next slide. And so this was just an example of University of Florida. They have a virtual visit for HIV video care series, and it brings it all through before they start the visit and how to get it connected and how to troubleshoot. So this is just some considerations of how to get used to this for your patients. Next slide, please. And so these are just some of our best practices. Embracing technology, not looking at it as a barrier, making sure to vet your telehealth equipment. Maybe you have to have an initial in-person visit, but in our model, we actually, with our prisoners, we've never actually seen them on site. We never required that first visit. But I think as we look at that hybrid approach, that's something that we will definitely need to make sure to consider. Don't just have telehealth for a patient one time and not make them use it again for another year. Let them use it often so that they can start to navigate and think about what they are able to do for themselves. And so with that, I will leave you with a lot of this information so that you're able to use that, but we're happy to answer any questions that you have right now.
Great. Thank you, Melissa. I know that there was a lot of information, just shared a lot of really great information. So I just wanted to provide the opportunity now, if anyone has any questions, you can feel free to chat in the chat or come off mute.
I had actually a couple of questions, but I'll try to prioritize them. Dr. Young, on the ID versus primary care treatment and the stats you put up there with the prison example, do you have one of our focuses is that we want to try to get FQHCs and primary care physicians to be more comfortable with treating HIV as a chronic illness kind of model. Do you have an opinion on that, given those stats from the prison example?
Yeah, and I think HIV management in 2021 is a little bit less complicated maybe than it used to be. A lot of the old antiretrovirals that we had a lot of side effects and toxicities and drug-drug interactions. And now something like a later generation integrase inhibitor and a couple of nukes, something like Biktarvy is pretty easy, straightforward to manage, not a lot of side effects. So it is a bit easier to navigate. And so I think some of those numbers might look a little bit different in 2021 than 8-10 years ago, but I do think subspecialty, at least consultation, is important. So here we do in infectious diseases, we manage all of our HIV patients at the medical center, partially because we're part of the AIDS clinical trials group and we have lots of clinical trials going on. We do have some primary care physicians who manage HIV, and they can always put in an EConsult. If they have a question, their patient has virologic failure, they're having side effects, their pill is too big, they're asking about injectables, something like that, then they have EConsults available to them. And as I showed, I mean, within 24 hours, typically we answer the EConsult question. So it works really well. And I think primary care physicians, as I mentioned with PrEP, I mean, here the vast majority of our PrEP is done by primary care, and they just typically put in an EConsult in the beginning just to see about testing and frequency of visits and all that kind of stuff. And then if anything pops up, they just ask questions again. So I think if you have a provider, if you have an ID trained provider, I think they could do something like EConsults very easily, and or sort of in what's called the ECHO model, where it's kind of really more telementorship, where you can kind of go through cases, give lectures, things like that about HIV management to primary care physicians to make them more comfortable.
And those consults, those type of consults right now, are they just in-house for you all at the medical center, or can somebody from the community call in and get a advice?
Yeah, right now our outpatient e-consults are just for people at our medical center, but then I do inpatient e-consults for 3 different community hospitals that don't have ID physicians there. So those are more inpatient oriented, and occasionally we'll have someone with, HIV, AIDS and an opportunistic infection or something, but those are mostly just other infectious disease issues. We'd like to expand.
Great, thank you. Thank you very much.
Great. Other questions?
Well, just one more quick one. I don't want to take up the time.
Go for it.
Dr. Young, I'm sorry, follow-up question on that. Is it mostly, do you ever do telemedicine at the bedside as a consult, or is it mostly peer-to-peer or provider-to-peer?
Yes, great question. So for the inpatient consults, we start with an asynchronous e-consult peer-to-peer, but at the 3 different hospitals. So we started trying to use the stroke robot because we do telestroke too, and that just was too cumbersome. So at each nurse's station, we have an iPad. So if I need to look at a rash, I often, ID physicians are the great social history takers. So I often have to take much more social history if somebody's there with a fever of unknown origin or something, about, sexual history and animal exposure and all this kind of stuff. So I can convert any of them at any time to a synchronous video visit. And it's through an encrypted platform called Teledoc. So again, that's a subscription, so that encrypts the visit to be HIPAA compliant, but it's very easy to use.
And you're comfortable seeing the patient like that and seeing them through the video? It works for you?
It works really well. And we, the disadvantage of not having a cart or like the stroke robot is you don't have the peripherals like Melissa was talking about. So one big advantage of the prison telemedicine program at UIC is, telephonic stethoscopes and the exam cam, where you have a high resolution handheld camera and you can look up close in someone's throat for thrush or something like that. There are a lot of advantages to having peripherals, but it just wasn't super feasible. And I think it works out well. And there are internists there who can listen for murmurs if there's an endocarditis case or something like that. So yeah, it works.
Right. You have hands in case you need it.
Yeah.
Awesome. Thank you so much. I appreciate it.
Excellent. So I just wanted to, first of all, say thank you so much to our speakers, Melissa, or Dr. Badowski, Dr. Young, that joined us, and wanted to just remind everyone that's on today, if you have not completed the needs assessment in the Google Doc or the Google form from Anna, to please do so as soon as possible so we can make sure we have all of that information, especially for the new cohort members. Again, we'll post a link to the Zoom recording and the slides in the Google group, and I see some people may be having challenges accessing the Google group. So if you are, please reach out directly to Anna and she can troubleshoot. And of course, everything that we post in the Google group that you need access to, if you're unable to access, we can always share that with you by email or via another platform, whether it be Dropbox or SharePoint. We can find a way to get you that information that you have access to as a cohort. If you have questions that were not answered today, we will be allowing anyone from the cohort to pose questions to our speakers that will collect and synthesize for the speakers in the next week. We just ask that you add that either into the Google group thread or you can email directly to Anna. And then we'll make sure that, to reach out to our speakers today to get some answers if there are any follow-up questions, and for those who weren't able to participate live today. And the last thing I just want to say is that we are scheduling in just 2 weeks our second session on improving client access, and we'll follow up with everybody with another Zoom invitation and link. And just want to encourage you to continue to interact in the Google group and look out for some more information about our next TA session. So thank you all. Thank you to our speakers and this really, really great information. We so appreciate you taking the time to share with us today.